So Colm, rotational atherectomy, certainly for the lesion that Andreas was talking about, where really we can't get anything across, rotational atherectomy is really the standard therapy there. You've got a lot of experience with rotational atherectomy. Talk me through your views about where rotational atherectomy stands in 2019.
I think it's been the mainstay of calcium modification for many years now. It's very old technology, while there have been some upgrades in the equipment which we'll come on to. But in essence, it's an oval-shaped device with diamonds on the front half that differentially modifies calcium. So it will shatter the calciums. You're not trying to debulk the calcific lesion. You're trying to disrupt the calcium to allow then good stent expansion. It's old technology, as we mentioned. It's an over-the-wire equipment, so that means you have to get a rotafloppy wire, which is an over-the-wire 300 centimetre wire into the distal vessel, so there's challenges associated with that. Because of the size, it's an 010 wire. It's a steel wire, so it's different to the wires we're used to working with day to day. So instead of wiring it directly, you're much more likely to have to wire with a standard wire and do wire exchange. So those are skills that an operator has to have. And then you bring down the rotablation, which, as I mentioned, is an over-wire system, and you try and modify the calcium. All those steps are different from what we do normally. So the great appeal of the cutting balloon, the scoring balloon, it's using your standard workhorse wire, your standard balloon technology, the monorail systems we're familiar with, and that's very familiar to a lot of users. To switch to use an over-the-wire system does require additional skill sets. If you're not doing it routinely, it becomes foreign to people. You're less likely to use it. And if, for example, you looked at the uptake of these technologies, in some centres it's 7-8% of overall cases. Your centre, Peter's centre, Andreas' centre, some other centres it's less than 1%. And that simply reflects that it is viewed as a complex procedure.
Traditionally, rotablation would have been an 8 French femoral sheath, it would have been a temporary pacing wire. How do you do it in Belfast?
Yeah, and of course that was back when you were trying to, in essence, debulk the lesion. Nowadays, most cases we saw today from the updated figures from our BCIS returns, 90% of our cases are done radially, and that's for a reason to reduce the complications for patients. You can do up to a 1.75 millimetre burn, a 6 French guiding catheter very comfortably. Most patients will take a 7 French guiding catheter, especially if you used a slender sheath. So we will do the majority of our cases via the radial approach. The temporary wire is an invasive procedure. A lot of complications, for example, TAVI relate to the use of temporary wires. So
right.
we don't use temporary wires anymore.
Yeah.
We try to keep the runs to a minimum. So we would do short packing runs, less than 5 to 10 seconds. I think the chances of the no reflow is when you do big long runs, you build up a lot of debris which then goes downstream. That's when you get the no reflow.
So in Belfast, would the strategy be, well look, let's just try this with a balloon? Or if you think you're going to use rotablation, would you just use rotablation up front?
I think we're so comfortable within the centre that we've got enough expertise that if you're thinking, I wonder, should I? You probably need to. And what you often find is that taking the rotablation up front will actually shorten your procedure.
Right.
Where you get into difficulty is when you try to modify, try to bully a lesion. Often the lesion doesn't give within the calcium, it gives at the interface between the calcium and other disease, which is then a tear, which leads to perforation and complications. So there's nothing like a shortcut to extend your procedure.
Peter, you've got a lot of experience with rotablation.
Yeah.
You're going to try to do this with a tiny burr and then scale up, or do you just go straight for the burr that you think is probably going to do the job?
I think as Colm says, I think we've moved away. We did look quite a lot of early two burr strategies, starting small, going bigger. But in essence, we're just trying to get through the lesion to modify it enough to get the rest of the equipment through and get adequate balloon dilatation. So my strategy would generally be probably use a 1.5 burr for most of the cases. And then I would take a 1-to-1 balloon, non-compliant balloon, and go up and make, if that adequately expands, I've done the job. I'll often use imaging as well to just clarify that I've done enough. And, what's really good with the imaging is to look for calcium fractures. So if you've modified it with calcium fracture and it's pretty obvious that you can see them, then I think you've probably done enough for most of the cases.
You have laser as well in Bournemouth. How do you decide laser or rotablation?
So, laser has some advantages over rotablation. The main one being that it works on a standard 0.14 wire, so you don't have to put a dedicated wire down. But it doesn't really work for very heavy calcifications. So the heavy calcified lesions, without doubt, rotablation. If it's moderately calcified and it's focal, then laser's quite efficient and quick, because you just have to apply it to the lesion and often it will work. Again, just to modify it enough to get the balloon down and finish the case. But I think, all these devices, we used to use laser to help us get the rotor wire down, but now with the microcatheters being so good, that's less of an indication.
So it's the CTO techniques kind of helping your more difficult angioplasty. So, and there's been sort of a technological step forward after about 20 odd years with rotablation, Colm. You got some experience with the new console?
Yeah, well, as you know, the old technology, you had to be in control of both hands and both feet at one time, and there's very few procedures that involves you to use all 4 of your limbs, assuming you have 4 limbs.
And breathe at the same time.
And breathe, so for the male, that's a very complex procedure. The new device has been modified so that you do not need the pedal anymore, you can control it all from the advancer. So it certainly has become much easier to use. Unfortunately, you still need the same wire, but there is a new wire coming along, a Rota Elite wire, which will have the same sort of one-to-one torque response that we have with our traditional or standard wires. So that will allow for you to wire it up front with the Rota wire and then move straight to use of rotablation. So the advances will certainly help in terms of the efficiency of the procedure and also the effectiveness of the procedures.